The patient with a mental health disorder. Overview of mental disorders. A psychiatric or mental health disorder is a complex, clinically significant behavioral or psychological syndrome that may impact the individual's ability to engage in daily activities of living. The cause may be related to behavioral, psychologic, or biologic dysfunction in the individual. The American Psychiatric Association has classified more than 200 types of mental disorders in the document Diagnostic and Statistical Manual of Mental Disorders, DSM-5. Each disorder has characteristic signs and symptoms. With the current policies of deinstitutionalization, more individuals with mental disorders are seeking dental and dental hygiene care in dental offices and clinics. Person-first language is used to refer to someone with a mental disorder, chronic disease, or disability. The person is emphasized first and not the disorder, disease, or disability. For example, refer to the patient as an individual with schizophrenia, not as a schizophrenic patient. Prevalence of mental disorders. In a meta-analysis of 175 studies in 63 countries, 1 in 5 respondents met the criteria for a common mental disorder in the previous year. About 29% of respondents had experienced a mental disorder during their lifetime. Women had higher rates of mood and anxiety disorders, while men had higher rates of substance abuse disorders. English-speaking countries had the highest lifetime prevalence of mental disorders, with North and Southeast Asia among the lowest reported prevalence. Anxiety disorders. Anxiety disorders are the most common class of mental disorders in the general population. Anxiety disorders are common with a global prevalence of around 7%. Euro-Anglo countries have prevalence over 10%, suggesting 1 in 10 people have an anxiety disorder. Anxiety is a normal reaction to stress. In anxiety disorders, the anxiety is exaggerated, resulting in excess worry and avoidance behavior that can impact day-to-day functioning. For formal diagnosis, the symptoms must be present for at least 6 months. Some individuals may have secondary problems of alcohol and other substance abuse. The abuse may be the result of an attempt at self-medication. Individuals with anxiety disorders often have comorbid conditions, including other mental health disorders, hypertension, gastrointestinal issues, thyroid disease, cardiovascular conditions, migraine, headaches, allergies, and/or a respiratory disease. Types and symptoms of anxiety disorders. Generalized anxiety disorder. Persistent, pervasive anxiety and excessive worry, but are not associated with life-threatening fears or attacks. May be complicated by depression, alcohol abuse, or anxiety related to a general medical condition. Symptoms include feeling restless, on edge, irritable, difficulty falling and staying asleep, difficulty concentrating, and muscle tension. Obsessive compulsive disorder. Frequent upsetting thoughts, obsessions, and when the individual tries to control them, there is an overwhelming urge or compulsion to repeat routines or rituals over and over. Symptoms include spend at least 1 hour a day with obsessive thoughts and rituals that cause distress and interfere with normal daily functioning. Thoughts or obsessions might include fear of germs, dirt, or intruders. Rituals might include washing hands, locking and unlocking doors, or keeping unneeded items and hoarding. Panic disorder. Panic disorder is characterized by sudden and repeated episodes of extreme fear and panic attacks. Symptoms center on panic attacks. A panic attack may be unexpected, uncued, or situationally bound, cued. A situationally bound panic attack invariably results from an exposure to a specific trigger, such as the dental office. Fear of being out of control during a panic attack. Physical symptoms during an attack may include pounding or racing heart, sweating, difficulty breathing, chest pain, and dizziness. Post-traumatic stress disorder. All individuals experience stressful or traumatic events, yet not everyone responds in the same way. Some people will develop post-traumatic stress disorder or PTSD, and others are resilient and manage the adversity and adapt. PTSD develops after a terrifying ordeal involving physical harm or threat or physical harm. Onset may be triggered by destruction to the home or family, or may result from a man-made disaster such as war, imprisonment, torture, rape, physical or sexual abuse, or other exposure associated with intense fear or serious threat to life. Signs and symptoms include flashbacks of the traumatic experience, and terror may be triggered by stimulus that can be readily associated with the original event. Dreams or recollections may cause the individual to feel they are reliving the event. Avoidance of places, events, or objects that are reminders of the triggering event. Loss of interest in activities that were enjoyable in the past. Hyperarousal symptoms including feeling tense, difficulty sleeping, angry outbursts, and may easily be startled. In children, symptoms may be slightly different and include bedwetting, acting out the scary event during playtime, or being unusually clingy to a parent or other adult. Risk factors for PTSD may include living through a dangerous or traumatic event, a history of family illness or substance abuse. Resilience factors for PTSD include seeking out support, either formal or informal, from family and friends, a positive coping strategy, and ability to function despite feelings of fear. So treatment, basic therapeutic approach. Lifestyle modifications include regular physical activity, adequate sleep, and avoidance of drugs and alcohol. Diagnosis and treat other medical and psychiatric problems. Pharmacologic treatment. Antidepressants, preferred as an initial treatment for anxiety disorders. Examples include fluoxetine, Prozac, paroxetine, Paxil, and sertraline, Zoloft. Side effects are headache, weight gain, tremor, irritability, and xerostomia. Anxiolytics. These are used only short-term because of the risk of dependency. Examples include benzodiazepines, Valium, lorazepam. These are highly addictive and must be carefully monitored. Side effects: confusion, dizziness, muscle memory impairment, weakness, difficulty in speaking, skin rash, and xerostomia. Beta blockers, taken on short-term basis for anxiety. These medications help to relieve the physical symptoms of anxiety, such as trembling, shaking, and rapid heartbeat. Psychotherapy, cognitive behavioral therapy, CBT. CBT is a combination of strategies to address the cognitive, behavioral, and emotional components of the anxiety disorder. May be conducted in individual or group sessions. Support groups are also helpful. Prolonged exposure PE therapy. PE therapy is used in treatment of PTSD and gradually exposes an individual to the traumatic event in a safe way and helps them cope with their feelings. Cognitive processing therapy, CPT. CPT is also used to treat PTSD and helps people to make sense of the traumatic event they experience. The dental hygiene care, personal factors. Each anxiety disorder has its own characteristic. Relationship with other people can be strained. Physical complaints such as rapid heartbeat, hyperventilation, tightness in the throat, and constant fatigue are common. Oral complications, xerostomia related to medications put the patient at high risk for dental caries. Individuals with the diagnosis of an anxiety disorder are at a higher risk of tooth loss. Individuals with mental health disorders have a 25% higher risk, caries risk. The odds for periodontal disease in a patient with panic disorder is 3 times that of someone without the disorder, but it was not higher in other mental health disorders. A patient with obsessive compulsive disorder may perform such excessive vigorous toothbrushing that gingival and dental abrasion may result. Appointment intervention. Review the medical history and medications carefully. Enhance the patient's sense of control. One technique is to establish a stop signal, which may consist of the patient raising the left hand when they are uncomfortable or need to stop a treatment. Explain each step to the patient and keep communication as open as possible. Cognitive distraction involves encouraging the patient to think about something besides the dental treatment. Headphones for music and relaxation can help to reduce the stress. Environmental changes can help reduce anxiety. An example would be the smell of lavender in the waiting room to relax the patient, but this needs to be used in addition to the previously mentioned techniques. Nitrous oxide sedation may be helpful to relax the patient. Effective pain control is needed. Use local anesthesia for non-surgical periodontal therapy. Attention to the technique to minimize discomfort is essential. Appointments are best scheduled in the morning. Eliminate unnecessary waiting in the waiting rooms. Length of appointment can be minimized and plan to prevent stress. Be alert to symptoms of panic attack, such as sweating or hyperventilation, and allow the patient to sit up and take short breaks. Depressive disorders. Mood disorders that include depressive disorders are another common classification of mental disorders. The prevalence of mood disorders for adults is 7.1% in the previous 12 months, with a lifetime prevalence of nearly 31% in the United States. Women are more likely to experience mood disorders. Onset is usually in the mid-20s, but it can occur at any age. Depression is the leading cause of disability worldwide. Types of depressive disorders. Major depressive disorder. Transient depressed moods occurs in the lives of most people. Sadness over unforeseen tragic events, illness, death, or disappointment in career or other life plans can cause depressed feelings. Major depressive disorders interferes with daily life. Some individuals experience only one episode of major depression in their lifetime, but it is more common to have multiple episodes. Postpartum depression. During the postpartum period, many physiologic and psychological stresses are related to the changes taking place in the mother's life. A moderate to severe depression within the first month postpartum, but postpartum depression, PPD, tends to peak at 2 to 6 months after delivery. The prevalence of PPD is estimated to be about 10 to 20%. Recent research suggests that fathers can also experience paternal PPD in the first 6 months after a birth of a baby, with prevalence rates of about 10%. It is critical to identify women with PPD because it can lead to negative mother-infant bonding and interactions that include maternal withdrawal, disengagement, and even abuse. The mother may be less likely to engage in preventive care and is less responsive to providing care to the infant. This may include engaging in appropriate feeding practices and oral health care for the infant and child. PPD may impact developmental milestones such as cognitive scores and nonverbal communication of the infant and toddler. Infants may also exhibit increased dysregulation of sleep and feeding. Negative infant behaviors are also typical, including excessive infant crying and fussiness. Signs and symptoms. Symptoms vary between individuals, but common symptoms include depressed mood or loss of interest or pleasure in activities present for at least 2 weeks. Feelings of hopelessness, worthlessness, or guilt. Fatigue and lack of energy, difficulty with memory and concentration, appetite disturbance, insomnia, early morning wakefulness, thoughts of suicide. The treatment. In the case of depression, one of the first things assessed is suicide risk. Hospitalization may be indicated when potential danger of suicide or harm to others exists. Basic therapeutic approach. Lifestyle modifications include regular physical activity, adequate sleep, and avoidance of drugs and alcohol. Diagnose and treat other medical and psychiatric problems. Pharmacotherapy. Antidepressants are preferred as an initial treatment of depressive disorders. However, they take 2 to 4 weeks to reach therapeutic levels. Selective serotonin reuptake inhibitors. Advantages. Tolerability better than earlier drugs, better compliance, safety, and overdose. Example, Prozac, Paxil, Zoloft. Serotonin and noradrenergic reuptake inhibitors. Examples, Cymbalta and Effexor. Dopamine norepinephrine reuptake inhibitor, Wellbutrin. Monoamine oxidase inhibitors. Use is restricted to patients who do not respond to other medications due to the drug-drug and drug-food interactions. Example, phenazine and trancypromine. Alternative therapies. St. John's worts may be used by some patients, but the evidence is not strong for its effectiveness, and there are potential drug interactions, so the patient should be encouraged to consult with their mental health provider. Psychotherapy. Psychotherapy combined with pharmacotherapy is more effective than either one alone for treating depressive disorders. CBT, problem-solving therapy, psychodynamic therapy, interpersonal psychotherapy. Electroconvulsive therapy. Electroconvulsive therapy is used in severe major depression disorder when the pharmacologic therapy and psychotherapy have not been effective. It is also indicated in situations where an immediate response is needed, such as for someone who is suicidal. Patient may experience confusion and short-term memory loss, may have cardiovascular side effect, and is contraindicated in patients with a history of cardiac arrhythmia or recent myocardial infarction. Dental hygiene care, personal factors. Self-care impairment and lack of motivation negatively impact the oral health. Symptoms not controlled by medication, such as difficulty with memory, may need to be considered when planning dental hygiene care. Individuals with depression may have poor diet quality, such as a higher intake of energy and dense foods that tend to be higher in sugar, which may increase the risk of dental caries and impact healing after periodontal therapy. Oral health implications, side effects of medications. Xerostomia, along with poor dietary choices, encourages growth of dental biofilm and increases the risk of dental caries. Omission of general health habits and neglect of oral care make the person susceptible to oral diseases. Adults with a diagnosis of depression were at 64% higher risk for having 6 or more teeth extracted. Those with depression are at 37% greater risk of being edentulous. Taste perception changes may contribute to a diet high in cariogenic foods and high level of sucrose. Appointment interventions. Assess, monitor the medication histories closely. Note side effects and contraindications related to new drug therapies. Review consultations with medical psychiatric specialists caring for the patient. Intraoral, extraoral examination. Check for signs of xerostomia. Approach. Provide positive enforcement and reassurance. Avoid negative guilt-inducing words. Depressed patients may needlessly blame themselves. Show genuine interest in the patient to build rapport. Preventive instruction, dental biofilm control. Teach patients and caregivers the need for daily measures to prevent and preserve the teeth and periodontal tissues. Xerostomia, manage caries risk with dietary counseling, office and home fluoride, saliva substitutes, and xylitol gum between meals. Implementation of care plan. Adjust dental light carefully and provided tinted sunglasses and eyewear for the patient with photosensitivity, a side effect of certain medications. Profound local anesthesia when needed for pain control. Provide in-office fluoride treatment after instrumentation. Use care to prevent postural hypotension. Sit the patient up slowly from a reclined position and have the patient remain seated for a few minutes before standing. Bipolar disorder. Bipolar disorder, BD, was formerly known as manic depressive disorder and involves mood changes from extreme highs, mania, to extreme lows, depression. The lifetime prevalence in the United States is approximately 4%. It is more prevalent in women, and the average age of onset is mid-20s. In those with BD, suicide is the leading cause of death, so they need frequent monitoring by a mental health professional. BD is the most costly behavioral health issue in part because of the high rates of comorbidities such as anxiety disorder, metabolic syndrome, substance abuse, and attention deficit disorders. The signs and symptoms of bipolar disorder. Manic episode symptoms include behaviors that are not consistent with the patient's usual behavior, including the following: inflated self-esteem, decreased need for sleep, irritability, attention gets focused on unimportant activities, excessive involvement in risky activities, extreme changes in energy, activity, sleep, and behavior based on the large swings in mood. Major depressive episode symptoms are the same as those described for depressive disorders. The treatment for bipolar. Both pharmacotherapy and psychotherapy are used during all phases of the disorder. Initially, hospitalization may be needed to protect the individual from harm or self or others. Pharmacotherapy, mood stabilizers. Example, lithium. The side effects: xerostomia, restlessness, joint and muscle pain, salivary gland swelling, indigestion, and bloating. Atypical antipsychotics are sometimes used in conjunction with antidepressants. Examples: Seroquel, Risperdal, Zyprexa, Abilify. Side effects: dizziness, blurred vision, rapid heartbeat, skin rashes, and drowsiness. Antidepressants are usually taken with a mood stabilizer. Prozac, Paxil, Zoloft, Wellbutrin. Psychotherapy. Cognitive behavioral therapy helps patients to learn to change harmful or negative thoughts, patterns, and behaviors. Family-focused therapy improves communication and coping strategies to aid in early recognition of manic and depressive episodes. Interpersonal and social rhythm therapy, IPSRT, is typically used in conjunction with other psychotherapies and is helpful in the maintenance phase of bipolar disorder. IPSRT focuses on helping individuals to maintain consistent daily routines to promote stability in the mood. If a patient was undergoing IPSRT, inclusion of oral hygiene procedures in the daily routines may be helpful in encouraging regular oral self-care. Psychoeducation educates the patient and family about BD and coping strategies. Dental hygiene care, personal factors. In a manic episode, many patients talk quickly, jump from one thought to the other, and have a short attention span. A tendency to argue and become irritable may be apparent. In a depressive episode, the patient may not be interested in oral self-care and be unmotivated. Oral health implications. Oral hygiene needs are often not a priority to the patient. Gingival tissues may appear abraded and lacerated because of overzealous toothbrushing with excessive pressure. Side effects of medications with implications for oral health and dental care include xerostomia, dysgeusia, and in part, a metallic taste in the mouth. Lithium usually has that side effect, a metallic taste in the mouth, or a taste of metal. Stomatitis and glossitis, loss of taste acuity, and dizziness. The appointment interventions. Carefully review medical and medication histories. Consult with patient's physician and psychiatrist as needed. Simplify the surroundings. Provide a comfortable, calm, and uncluttered environment. Patient instruction may be difficult due to a short attention span. Use direct, simple instructions. When applicable, help the patient's caregiver to learn procedures for dental caries prevention and periodontal health. Manage caries and periodontal risk with saliva substitute, office, and home fluoride applications, dietary counseling, and sugar-free xylitol gums or mints between meals. Chlorhexidine gluconate mouth rinse may be prescribed for short intervals due to reduce caries risk and aid healing after NSPT. 3 to 4 month continuing care appointments may be needed. Feeding and eating disorders. Feeding and eating disorders are serious disturbances in the amounts and types of foods consumed. The lifetime prevalence ranges from 0.9% for women and 0.3% for men for anorexia nervosa to 1% for bulimia to 2.8% for binge eating disorder. Prevalence of other feeding disorders such as pica and rumination disorders is unclear. Identification and referral of a patient suspected of having an eating disorder for medical evaluation may be life-saving because serious medical problems may exist and psychiatric therapy is indicated. An interdisciplinary team approaches for successful rehabilitation of an individual with an eating disorder involves at least medical, psychiatric, nutritional, dental, and dental hygiene professionals. Types and symptoms of feeding and eating disorders. Pica. Consumption of non-food items typically occurs in children, but is also common in adults, particularly those with mental disorders and or intellectual disabilities. Diagnostic criteria include persistent eating of non-food substances such as dirt, clay, starch, gum, or ice for at least a month. Consumption of non-food items may replace healthy foods and lead to nutrient deficiencies that can impact immune response and healing. Anorexia nervosa. It is characterized by refusal of the individual to maintain body weight over the minimum normal weight for age and height. The aversion to eating results in life-threatening weight loss. Anorexia nervosa has the highest mortality rate of any mental disorder. Commonly begins in adolescents or young adults. The signs and symptoms. Restriction of energy intake resulting in severe weight loss with emaciation, waif-like appearance. Intense fear of weight gain and becoming fat. Body image distortion. Purging by vomiting, laxatives, or excessive exercise. Malnutrition can have long-term impact of the bone mineral density, osteopenia, and osteoporosis. Vital signs. Low pulse rate, hypotension, decreased respiratory rate, and low body temperature. Metabolic changes, gastrointestinal, cardiovascular, hematologic, and renal system disturbances. Amenorrhea, missed menstrual periods. Bulimia nervosa is a mental disorder marked by recurrent episodes of uncontrollable binge eating that occurs on an average of once a week for 3 months. 2 types of compensatory behaviors are seen in individuals with bulimia nervosa, known as the purging type and the non-purging type. Because of the fear of becoming overweight, self-induced vomiting after eating or the use of laxatives or diuretics is characteristics of purging type. The non-purging type uses strict dieting, fasting, and or vigorous exercise. Signs and symptoms. Normal body weight or slightly overweight is typical, in contrast to thin, anorexic persons. Comorbidity with other mental disorders is common, especially depression and bipolar disorder. Lifetime prevalence of alcohol or substance abuse in 30% of people. Chronically inflamed and sore throat, swollen salivary glands, enamel erosion, and dentin hypersensitivity due to frequent exposure to acid gastric fluids. Severe dehydration may result from purging. Food consumed during a binge includes 65% breads and pastas, 56% sweets, and 40% salty snacks, which may be more cariogenic. Binge eating disorder. Recurrent episodes of binge eating without compensatory behavior seen in bulimia nervosa at least once a week for 3 months. The signs and symptoms. Occurs in normal weight, overweight, and normal weight, overweight, and obese individuals. Binge eating is associated with feeling embarrassed or guilty about how much one is eating. Comorbid disorders include mental health disorders such as bipolar, depressive, and anxiety. Eating large amounts of food quickly in a short time, eating alone or in secret, and frequent dieting. Diabulimia. Diabulimia is defined as the restriction or omission of insulin in an individual with type 1 diabetes mellitus in order to lose or prevent weight gain. This condition has been documented since the 1970s, but there are no recognized diagnostic criteria in the DSM-5. Diabulimia is most often seen in adolescents and young women. These individuals are at an increased risk of microvascular complications such as renal failure, neuropathy, heart attack, stroke, and death. The signs and symptoms: rapid weight loss, obsession with body size and shape, and dissatisfaction with body image, ketone or fruity smell, persistent high hemoglobin A1C, eating behavior similar to bulimia nervosa, frequent emergency room visits or admission for diabetic ketoacidosis. Orthorexia Nervosa, characterized by pathologic or disordered healthy eating with a focus on the quality of food choices resulting in a negative effect of health. This condition is not recognized by the American Psychiatric Association in the DSM-5 and did not appear in the peer-reviewed literature until 2004. Proposed diagnostic criteria include compulsive behavior or preoccupation with restricted dietary practices believed to promote health. Dietary restriction tends to escalate over the time with elimination of entire food groups and may engage in cleanses, partial fast, and to detoxify. Violation of dietary restriction causes anxiety and shame, malnutrition or medical complications from the restricted diet, impairment of social, academic, and vocational functioning. Medical complications. Medical complications are primarily associated with anorexia nervosa in people with bulimia who engage in purging behaviors. Problems include dehydration, electrolyte imbalance, protein malnutrition, and cardiac arrhythmia. Self-medications include abuse of laxatives and diuretics, which contribute to gastrointestinal disturbances, esophageal tears, amenorrhea, or menstrual irregularities. Treatment. Multidisciplinary team treatment for eating disorders is considered best practice. The primary objectives are to promote weight gain and restore the nutritional status. Treatment may require months or even years. Typically, outpatient treatment is recommended. So if someone has been hospitalized for treatment, it suggests that they are at high risk for medical complications and medical onset is needed. Pharmacotherapy, antidepressants, primarily in bulimia nervosa. Examples: Prozac. Side effects: headache, weight gain, tremor, irritability, and xerostomia. Psychotherapy. The goal of therapy is to help the individual discover the underlying causes of the problems and source of the disordered eating behavior. Cognitive behavioral therapy is the first line of treatment in bulimia nervosa and diabulimia. Interpersonal therapy. Family-based therapy is recommended for younger patients. Nutrition therapy. Registered dietitian nutritionists who advanced training in eating disorders work as a part of the interprofessional team to conduct a full nutrition assessment, diagnosis, and individualizes a plan for medical nutrition therapy in collaboration with the team. This in-depth type of nutrition counseling is beyond the scope of practice for dental professionals. Dental hygiene care, personal factors, anorexia nervosa. Individuals with anorexia nervosa are frequently engaged in excessive exercise and preoccupied with food and weight loss. Frequently, the person is a high achiever and highly motivated scholastically, but may be socially isolated and withdrawn. Suicide risk is elevated in anorexia. Bulimia nervosa and binge eating disorder, the patient is well aware that the eating habits are abnormal and as a result may suffer low self-esteem and guilt feelings. Oral implications. Dental erosion or perimolalysis. This is the chemical erosion of the tooth surface by acid from regurgitation of stomach contents. After vomiting, acid is retained by the tongue papilla and provides longer contact with the palatal surfaces of the maxillary teeth. Individuals who engage in self-induced vomiting have 5 times greater risk of dental erosion. Because of perimolalysis, the earliest evidence of bulimia or binge eating purging type of anorexia may be on the smooth palatal surface of the teeth. The lingual surfaces of the maxillary anterior teeth appear translucent and glass-like. With time, the erosion extends over the occlusal and incisal surfaces and chipping may occur. Restorations in posterior teeth may appear raised because of erosion of the enamel around the margins. Dental caries. An increase in dental caries incidence is found particularly in the cervical caries. Demineralization results from pH change in the saliva, from xerostomia, and from the large quantities of cariogenic foods ingested during binges. Mucosal lesions, nutrient deficiencies, especially in the B vitamins, may result in angular colitis, glossitis, inflammation, inflammation of the pharynx, or a burning sensation. Periodontal manifestations. Nutritional deficiencies with inadequate control of dental biofilm due to depression may predispose the patient to gingivitis. Saliva. The decrease in quantity, quality, and pH of the saliva limits its buffering and lubricating properties. Dehydration of the oral tissues occur. Body fluid is lost from vomiting, and the use of diuretics may result in xerostomia. Xerostomia is also a side effect of the antidepressant medication prescribed for patients with bulimia and anorexia. Hypersensitive teeth. The loss of enamel and the exposure of dentin results in sensitivity, which can be especially notable for the maxillary and anterior teeth. Trauma. The soft palate can be traumatized by fingers, comb, pencils, or toothbrush used to induce vomiting. The same implement may inquire the mouth at the commissures. Pharyngeal trauma is caused by a large food bolus that is swallowed or regurgitated. Callus formation or scars on fingers or knuckles used for self-induced vomiting may be observed. The parotid gland. Enlargement may occur for 2 to 6 days after a binge. The cause of enlargement is not known. The degree of the enlargement increases with the frequency of vomiting. The gland functions normally and is not sensitive to palpation. Bruxism. Tooth wear is related to stress and tension. Taste. Taste perception may be impaired. Temporomandibular joint disorders, TMD. Self-induced vomiting may cause dislocation or subluxation of the mandibular condyle due to the excessive opening and result in symptoms of TMD, including headaches, facial pain, and sensitivity to palpation. Appointment interventions. Present a non-threatening, non-judgmental demeanor. Develop rapport through mutual respect and a trusting relationship. Recognize that denial of an eating disorder is common. Be aware to answer to medical and personal history questions concerning diet, medications, and use of laxatives and diuretics, and weight loss may provide strong suspicion of a feeding or eating disorder. Assess the nutritional status through use of dietary assessment. Record the vital signs. Perimyelitis and dental caries prevention strategies include reduction in consumption of cariogenic foods, provide list of suggestions for substitutions. Improvement in oral self-care. Show use of appropriate brushing and flossing with additional interdental aids if required for biofilm removal. Clean the tongue. Avoidance of brushing after vomiting. Demineralization of the tooth surface by the acid from the stomach starts immediately on contact. Brushing may remove additional enamel and dentin. Remineralization after vomiting with an alkaline rinse of sodium bicarbonate solution to neutralize the acid. Dental hypersensitivity is managed as follows. Office application of fluoride varnish. Use fluoride dentifrice at least twice daily. Daily application of 1.1% neutral sodium fluoride toothpaste or gel. Avoid acidic foods and beverages. Xerostomia management includes advise sugar-free mints or chewing gum containing xylitol to stimulate the saliva flow. Recommend saliva substitutes. To reduce problems caused by hypersensitive teeth, choose sugar substitutes in acid-free foods and beverages. Moving on to schizophrenia. Schizophrenia is a complex, chronic mental disorder. Disturbances in feeling, thinking, and behavior significantly impair function to a level below normal for the individual. The prevalence of schizophrenia is 0.3 to 0.7%. The onset is usually between the ages of 16 and 30 years. Men tend to develop symptoms at an earlier age than women. Genetic factors are strong contributors to risk for schizophrenia. Associated medical issues such as cardiovascular disease, obesity, diabetes, and metabolic syndrome reduce life expectancy. About 10% to 13% of people with schizophrenia attempt suicide, and 4% to 6% die as a result of suicide. However, research conducted with a large Canadian community-based sample found 39% of those with schizophrenia had a lifetime prevalence of attempted suicide and were 15 times more likely to attempt suicide than someone without schizophrenia. The signs and symptoms of schizophrenia. Symptoms fall into 3 categories: positive symptoms, negative symptoms, and cognitive symptoms. The positive symptoms are those that reflect unusual, exaggerated behavior and include hallucinations that may include hearing voices, delusions, disorganized thinking characterized by the person having difficulty organizing thoughts or connecting them logically, movement disorders such as agitated body movements, people with positive symptoms may lose touch with reality and the symptoms may come and go. Negative symptoms are associated with disruptions in normal emotions or behaviors and may be mistaken for depression. The symptoms include the individual may have a flat affect, meaning the person may show no emotion, lack of pleasure in activities once enjoyed, inability to start and carrying out a task, little communication even when forced to interact. These individuals have difficulty with everyday tasks such as oral self-care. Cognitive symptoms are less obvious and may be difficult to recognize. These symptoms are poor executive functioning, meaning difficulty with understanding information and using it to make decisions, difficulty paying attention, challenges with working memory, or the ability to use the information immediately after it is learned. The prevalence of substance use disorder, SUD, is high among patients with schizophrenia. Prevalence of any SUD was approximately 42%, with over 27% using illicit drugs, 26% using cannabis, 24% using alcohol, and 7% using stimulants. Over 60% of patients with schizophrenia use tobacco. The treatment. The response to initial treatment can be a predictor of the long-term prognosis. The prognosis has generally considered guarded to poor. Evidence shows that although deterioration may occur during the early years, the condition may stabilize with treatment during middle age. Pharmacotherapy. The objectives of treatment are to reduce or alleviate the delusions, hallucinations, and other symptoms that enable the patient to function on a daily living. The use of antipsychotic medication has improved the outcomes of treatment. Typical antipsychotics are used to block dopamine receptors and are effective against positive symptoms with less effect on negative symptoms. Examples: Thorazine, Haldol, and Etrifon, Trilefon. The side effects are xerostomia, persistent muscle spasms, tremors, restlessness, and long-term use can lead to tardive dyskinesia, uncontrolled muscle movement, which commonly happens around the mouth. Atypical antipsychotics were developed in the 1990s and are the second-generation antipsychotics. Examples are Clorazol, Seroquel, Risperdal, Zyprexa, and Abilify. Side effects: xerostomia, dizziness, blurred vision, rapid heartbeat, skin rashes, and drowsiness. Psychosocial therapy. Psychosocial therapy is utilized once the patient is stabilized on antipsychotic medication. The treatment is used to help general support in dealing with the challenges of the illness, such as self-care, work, interpersonal relationships, and communication. Rehabilitation, once stabilized, includes social and vocational training, so a person with schizophrenia can function in the community. Family education is also essential to help them learn coping strategies and problem-solving skills to support their loved ones. CBT focuses on thinking and behavior and helps the person with schizophrenia manage symptoms that remain despite medication. Dental hygiene care, oral implications. Overall degeneration of the health factors may have occurred because of neglect or diet, exercise, sleep, general cleanliness, personal grooming, and oral care. Concurrent alcohol and other drug abuse, as well as smoking, can influence dental and periodontal health. Individuals with schizophrenia have higher rates of dental caries, missing teeth, and fewer filled teeth, suggesting either a lack of access to dental care or failure to seek dental care. Xerostomia, coupled with lack of attention to self-care, may lead to an increase in rampant dental caries. Those with schizophrenia who have higher rates of periodontal disease may be a result of lack of self-care coupled with lack of dental care and tobacco use. Appointment planning. Elective dental and dental hygiene treatment cannot be carried out until the schizophrenia is stabilized. If the patient decompensates, such as hallucinates or exhibits bizarre behavior during a dental or dental hygiene appointment, immediate referral is needed. Telephone numbers on the patient's mental health care provider should be kept in an easily accessible location for quick referrals. Appointment intervention. Because schizophrenia is often a lifelong disorder, planning for future oral health is essential. Review the medical and medication history. Analyze drugs for possible side effects that require appointment modifications. Consult with the mental health provider relative to medications, alcohol, and other substance abuse, and medico-legal competence for informed consent. Negative symptoms are associated with poor oral health and a greater need for periodontal treatment. Plan a simple routine. For a series of appointments and maintenance, use a familiar, organized routine that is comfortable for the patient. Decrease stimulation. Create a restful atmosphere. If background music is present, keep it low and soft. Management of the risk for caries, periodontal, and oral cancer includes the following. Oral self-care instructions to improve biofilm removal on a daily basis. When applicable, evaluate the patient's personal caregiver for attitude and knowledge and provide information and instruction. Diet assessment and counseling to assist the patient making non-cariogenic food choices. Encourage use of xylitol-containing gum or mints when cariogenic snacks or beverages are consumed between meals. Office and home fluoride, saliva substitutes may be helpful in patients with severe medication-induced xerostomia. Tobacco cessation may be more difficult for people with schizophrenia because nicotine withdrawal may cause psychotic symptoms to worsen. So the dental professional must collaborate with the medical treatment team to closely monitor the patient. Use a mouth prop to assist the patient with tardive dyskinesia. The patient who does not have control of mouth movements might appreciate the stability. Mental health emergency, psychiatric emergency. A psychiatric emergency in a dental clinic or private dental practice would be rare. The most common causes of an emergency include panic attacks, atypical drug reaction, and schizophrenic or manic decompensation. Patients at risk for emergencies. Patient with significant psychiatric history. Patient with a known substance abuse history. Patient new to the clinic or office, not known by the practitioner. Prevention of emergencies. Prepare a complete history. Collect as much information as possible. Consult with the patient's physician and psychiatrist. Be alert to risk and characteristic symptoms of each disorder. Apply all the principles of stress management. Know the patient's medications and when they are taken. Request the patient's or caregiver of a company to have readily available any necessary medication that may be effective during an emergency. Develop rapport with each patient. Avoid confronting the patient and present a non-threatening demeanor. Preparation for an emergency. Attend to surroundings such as door access, objects in the room. Arrange for colleagues to be aware of the possible needs of a special patient appointment. When possible, plan for an assistant to participate in clinical procedures. Review characteristics of possible emergencies and have necessary equipment ready. Keep names and contact information of the patient's case manager, psychiatrist, and responsible family members in the record in a prominent position for ready reference. Intervention. Stay with the patient. Request colleague to contact patient's case manager, psychiatrist, or other responsible person. Maintain a calm, serene manner. Talk quietly but firmly. Move the patient to a quiet, less stimulating environment. The dental equipment and environment may have contributed to the patient's disturbance. If you think the patient might be suicidal because of the individual mentions wanting to die or kill themselves, try to remain calm and implement the 5 action steps of be the one to ask. Directly ask the patient, are you thinking about suicide? Asking in a direct manner can open the door for the individual to share their feelings. Be the one to keep them safe. Showing support for someone can put time and distance between the person and their chosen suicide method. Be the one to be there. Being present shows support for the person at rise. This can be life-saving. Be the one to help them connect. Call the Suicide Prevention Lifeline, 1-800-273-TALK, 8255. Your call will be routed to a local call center, and they will walk you through resources available to assist, and if the patient is willing, have them talk to a mental health professional. Last one, be the one to follow up. Following up to see how the individual is doing has been shown to reduce the number of suicide deaths. Documentation. The patient with a mental health disorder must complete a health history with details of the medical problems and medication history at the initial appointment. Follow up with progress notes at each succeeding appointment to review all procedures and medications for changes. The following list suggests the minimum information to include in the permanent record. Resources for assistance in a convenient place in the event of need to contact. Telephones, emails, and working addresses for physicians, psychiatric, family, and emergency sources. Progress notes for each appointment and other contacts to update all personal data and treatment, and contact and correspondence with specialists and others.